We are a social enterprise working in the area of improving access to quality primary healthcare in rural and semi-urban areas. As many of us are aware that there is an acute shortage of doctors in India, and people in rural areas many a times have to seek access from informal providers or delay in seeking their care. What we do is that we operate e-doctor clinics in rural areas. These e-doctor clinics are nurse-assisted digital clinics, wherein a patient walks in and the nurse facilitates a video consultation between a patient and a doctor. As of date, we have about 25 such clinics in 3 states in the country. So when the COVID crisis first came in around 22nd or 23rd March, we were initially not expecting it to come that fast to rural India. We were thinking that this probably will take some weeks or months maybe to actually strike rural parts of the of India where our operations are. But suddenly I got a phone call from one of our operations managers that we have clinics in a place called Bhilwara in Rajasthan, and suddenly there was a huge spike in COVID cases, and some of the COVID cases were in the communities where we actually serve. So our first reaction was to immediately close down the clinics because we were not sure about what given that it is such a contagious disease, what would be the risk to the the nurse who's at the clinic. But then we also felt bad, right, that we are in healthcare, and we were kind of in a way closing the services and running away, right, from our duty. So then I remember it was at I think 10:30 p.m. in the night on the same day. We kind of got into a meeting with some of our senior leadership as well as operations team, and we said that we now know that this is not the way we could operate. Opening the clinics will take us some time, but what are the other ways we could kind of serve the community? You can imagine, in rural and semi-urban areas, there is a lot of misinformation as well and panic around the disease. So we then immediately started calling created a training and a counseling material for our nurses, and then immediately called up patients whose phone numbers we had in our database, and actually did kind of a counseling for COVID, effectively a telephonic counseling for each patient for COVID. And that kind of went in for about 15-20 days, right, where we had 5-6 people daily calling in, all the all our patients whom we could reach through a phone number, and explaining to them about what social distancing is, what good practice of hand washing is, and what is kind of some of the facts around COVID, so also to dispel some of the notions around it. We then also immediately upgraded our technology systems to actually enable a contactless consultation. So when we mean a contactless consultation, patients were advised not to come to the clinic but actually seek consultation from the doctor over a digital medium. Now this sounds quite easy in urban India, but in rural India, with a very low penetration of smartphone as well as very low penetration of internet, this became a challenge, right? So when we were designing the intervention, we realized that we could not only rely on an app, right? So we created a website which could actually work on a mobile phone. We also immediately started a helpline number which was manned by a nurse, right? And that helpline numbers and phone number, as well as the website link, was then sent as an SMS by these counselors to about 100,000 patients that we have, right? And so the calls actually served two purposes. One was counseling, the other was actually requesting or telling the community that if you need a healthcare service like this, you could kind of come and seek. Then the other thing that came in is that while one could do a telephone, teleconsult, whether through an audio or a video, but what about medicines, right? So now again, in rural areas, pharmacies were also not some of them were open, but not every pharmacy was open. So what we created a mechanism was that when the telephonic when the contactless consultation was over, But at the end of the day, our nurses provided door-to-door medicine delivery to the patients who had consulted on the system. So in the morning, let's say from 9 a.m., the consultation started. At 5 p.m., we got a list of how many patients who had consulted. We split it across the different centers, and then we actually provided medicines door-to-door to the patients' doorsteps, right? Since then, we have been able to do more than 2000 contactless consultations on our new technology system. These are consultations who have been provided medicines as well, and so in a way complete patient experience consultations. We also called up, as I mentioned, during our telecalling facilities, about 5,000-6,000 households, to provide them information and counseling about COVID services. We have provided our technology solutions to many other non-profits who were looking to serve their communities. Many hospitals have taken it. Many individual doctors have also kind of signed up on our technology system to be able to do that. And our plans going forward are to see that can we actually do 20,000 consults a day on the technology system, across all mediums combined, right? These are ambitious numbers, but I think given that we have been able to kind of garner these partnerships, right, I think having the right partners on our side, I'm pretty confident that we should be able to achieve those numbers. And the idea is that our plan is to see how we can mainstream telemedicine, and with the idea that how does telemedicine and digital health systems, how will they be customized for rural India, right, with low penetration of internet, low smartphones, probably lower literacy levels as well. So our plan is to kind of say that, okay, this is the time where technology could disrupt healthcare services delivery, especially for for Bharat, as we